Welcome to Scrub In, a podcast where purpose meets care. We are more than just a podcast. We are real stories of hope, expert health advice, and inspiring conversations with the people behind the scrubs.
This podcast will leave you informed, inspired, and reminded of the purpose that connects us all. It's the voice of humanity in healthcare, uplifting, honest, and full of heart.
Featuring hosts Dr. Kendall Barton, Keisha Morris, and Alice Rausch. You can listen and subscribe on Apple Podcasts, Spotify, Google Play, and YouTube. Or visit bayhealth.org/scrubin to learn more. Now, let's scrub in. Here's our next episode.
Hello, and thank you for joining this episode of Scrub In. I'm Alice Rausch, joined by Kendall Barton, Dr. Kendall Barton. Thanks for joining us. To our new listeners and also our returning listeners, thanks for coming back.
Absolutely, and we'll jump in today with our quote, which is, "I have come to see that my job is not just to operate on the brain, but to care for the person whose brain it is." And that is by world-renowned neurosurgeon Dr. Henry Marsh.
Oh, thank you. Fitting topic for today because we are talking about back pain, headaches, and surgery, what you really need to know. And we have some special guests joining us as well.
And we are so excited to have two of our own neurosurgeons here today, Dr. Kaitlyn Melnick and Dr. Aaron Sigler. So thanks for joining us today. And why don't you get us started by telling us a little bit about yourselves?
So, like you said, my name's Kaitlyn Melnick. I grew up in Dover, Delaware. Technically, it was Wyoming, Delaware. I went to Caesarani High School. And then did medical school at Jefferson, did my training at University of Florida in Gainesville, Florida, and now I've been back here for about a year and a half.
Thank you for having us, by the way. My name is Aaron Sigler. I am also from Delaware originally. I graduated from Seaford High School and I went to the University of Delaware. I did my medical school out west at the Kirksville College of Osteopathic Medicine. I came back to the East Coast, did my residency in New Jersey, and did a fellowship in Cleveland before I went and did my first job in Louisiana. I moved back here about a little more than 3 years ago, and been practicing ever since.
A lot of times people talk about how healthcare can be a calling, and for both of you to be from Delaware and coming back caring for people in our community is so exciting. Tell us a little bit about the why behind what got you started in healthcare to begin with.
I think for me, it very basic, like I just wanted to help people, and as I went through my education, trying to figure out what route that would look like, medicine always felt like the most natural to me. And I think my grandfather had been a physician, and he was a primary care doctor in a very small town in Pennsylvania, and I had heard my whole family talk, like he was God on earth, and he had delivered all these babies and all this stuff that he had done for this small town, and that just was so inspiring to me that I think that's a good bit of why I went into medicine. And then in terms of choosing neurosurgery, I think you kind of find your calling in medical school, and neurosurgery is just unmatched in terms of what we're able to do for patients, and I couldn't be happier with this field. Yeah.
Awesome.
I think we actually have a lot of overlap in that response, and I was thinking about this when we were introduced to what we were going to be talking about today, and I think it really comes down to three experiences, and I have to say, and shout out to my mom. My mom is fond of reminding me that I was basically saying from 2 years old, "I be doctor." Obviously, I've become more articulate since then, but the sentiment is still the same. It was also in high school, I got an opportunity to observe in a class in Seaford High School called Health Career Internship, where I got to go in the operating room for 2 days, and that was down at Tidal Health in Seaford. It was then Nanticoke, and got to observe, and I really fell in love with the dynamic of the operating room. At that point, there was a possibility that I could do anesthesia or surgery. I just really liked the team dynamic of the operating room. And ultimately it was medical school that really refined the interest as I went through anatomy and physiology and learned about all the systems. The final one we really went to, and that's not why I chose it, but the first one we did was spine, the final one we did was brain, and I love the architecture of the spine, and I'm fascinated by the brain. Not to get too long-winded on this, but the other part of it, the more fanciful part of it is, I am very into fantasy novels and role-playing games, and I am almost always drawn to play one of the magic users. They're the keeper of the secrets and the mysteries. I kind of feel that way about neurosurgery and neurology and anybody in the neurosciences. Neuro system is one of those systems where, yeah, we understand an awful lot about it, but there's still an awful lot we don't understand, and you have to be very comfortable with that uncertainty, I think.
That's awesome. Well, first off, I feel like we need to have an offshoot podcast for me and you to nerd out.
Yes.
But going into like what you do as an actual neurosurgeon, I mean, people always joke about it. Well, it's not brain surgery. So for all of those listeners that have no idea, what's the daily life like for a brain surgeon?
Well, I think having just finished my training, there's the training side of thing, and then there's the attending side of things. So in residency, which neurosurgery residency is now 7 years, it's essentially 7 years of 80 hours a week, which normally is around 5 a.m., sometimes more like 4 a.m. until 5 to 7 p.m. every day, working every other weekend a month, and basically just doing surgery all day long. And that's hard work, but there's a lot to learn for neurosurgery, so it makes it all worth it. Now, as an attending, I think things get quite a bit easier. So now most days look more like maybe 8 to 5, with some days being fully in clinic, some days being fully in the OR, and then we both alternate call where at any given time one of us is covering call in the hospital, which can be very unpredictable. And I think that's one of the fun things about neurosurgery is that on any given day you really don't know what your day holds for you until it happens. And then even not on call, I can get a message that one of my patients who I did surgery on is having a postoperative problem and I need to work on that. And every day kind of changes, and you just don't know until the day unfolds. I think that's really fun.
I don't have much to add on to that.
Yeah.
I think that was pretty succinct. It's one of those hurry up and wait specialties, I think, where there's times when you're really moving fast and other times when you're just kind of hanging around and doing the run-of-the-mill care, and then you got to go again. So, well said.
Yeah.
Switching gears a little bit to how you take care of yourself. You take care of other people all the time, but one of the important things too is, what do you do to stay healthy? How do you take care of yourself?
Well, my New Year's resolution is to start going to the gym. But we're halfway through January and that hasn't happened
We're
yet.
still very early. We're still very
We're
early.
not halfway.
There's still
It's
time.
not halfway.
But I do run, even without going to the gym. I do run just to get some endorphins and things like that. And I try to optimize my sleep hygiene and make sure I'm getting a good night's sleep, because that's so important for just our overall body's health. The other thing I do that just brings me a lot of joy is just listening to music. On the way down here, my volume's all the way up and I'm singing to those songs, getting myself hyped up. And I do that on the way into the OR, on the way into clinic. It just kind of brings me joy.
We're both music lovers.
Yeah.
I also need to get more active in the gym. I was doing pretty well there for a while, and then the holidays came, and that's kind of not been as good as it should have been. So there's that. I love to cook. I find it very relaxing, and I have lived all over the country and traveled a little bit internationally. And there's a lot of different cuisines, and every place I've lived, I've tried to embrace the culture in some fashion. My most recent, other than Delaware, was Louisiana, where I really embraced that culture, and it's such a rich, culture of food, music, all of that. I also enjoy reading, just hanging out with friends and gaming.
So, important question. You said you both like music, and you're both surgeons. What is your go-to pump-up surgery song?
Oh, there's not one song. I like a lot of different genres.
Artist?
Yeah. I don't even have my favorite artist, and I honestly I shouldn't say this on the podcast, but my favorite artist is Juice WRLD, which is like a emo rapper kind of guy basically. But that's who my favorite is right now. But pump up, I really like rock songs like System of a Down, or because they just get you going.
Those are high energy songs, and I'm loving what I'm hearing.
Yeah.
All right.
But my playlist in the OR is a mix of a lot of different things, because I think in the OR everybody should hear a song that they enjoy listening to, and it should have some variety. So
Pump up would definitely be hard rock or heavy metal in some cases. But as far as the OR, it's very eclectic.
Yeah.
Some days I turn on the classic rock. Sometimes it's 90s alternative. Sometimes it's whatever my Amazon soundtrack brings to us, which can sometimes take us on an interesting journey. So,
In December, for me at least, it was all Christmas.
Sam.
Yeah. Some of our OR staff doesn't like listening to Christmas music, but too bad. I get to decide for listening to
It's
Christmas
just one
music.
month, right? It's just 1 month.
It's just 1 month. That's the thing. It's 1 month.
Very
Exactly.
cool.
So, and I think there's a lot about brain surgery that our listeners aren't very privy to, because we mostly learn about it from what we see in Hollywood, which is mostly taking someone's skull off and doing surgery on their brain directly. What are some of the other procedures and surgeries that you guys do on a day-to-day basis?
I feel like it's a good question for you.
So I think one adjustment to maybe what people think is that neurosurgeons, especially in training but also out in practice, the vast majority of what we do for all of our training is spine. Brain is very interesting, and I think a lot of neurosurgeons really think of themselves as a bit of both.
Mm-hmm.
And one of the things that we do is sort of kind of have to decide which way you're going to lean more into in terms of advanced training and what you want to do. At least that's how one of my mentors taught us. I think some of the things that I would want people to understand is that some of what you see portrayed is a little misleading, if you will. I think some people have it in their mind, and this is the one that I have to tell people, I kind of have to qualify to people. When I talk about a craniotomy and I remove a portion of skull to do a surgery, whatever that, whether it's taking out a blood clot or removing a tumor or whatever it is that we're doing it for, I think they have the impression that we use the saw that is actually for autopsies. We make a complete 360-degree spin around the head and pop it off like a can top or something like that. That is not how that's done, because that is only done on autopsies, because you will destroy several very important blood vessels if you do that you can't fix.
Mm-hmm.
So it's more focused, more precise, obviously. Neurosurgery is all about precision, so it's a more focused specialty, I think, than some people recognize or realize, partially because of Hollywood. So
The other thing is I just had a patient the other day ask me like, oh, I'll be awake during the surgery. I was like, no. We do awake surgery occasionally, but those are few and far between. The vast majority of brain surgeries are performed asleep. And we can monitor nerves and things like that without having the patient awake and participating in the operation. So yeah, they were a little scared, and I said, oh, no. No.
You will be sleeping.
Yeah, you're going to take a nap.
yes.
Awesome.
Well, with spine surgery being one of your more common surgeries that you do, how does someone even begin to know that they need to come see a neurosurgeon?
Yeah, so I think the biggest misconception about spine surgery is that for the most part, spine surgery doesn't treat spine pain. There's like very isolated exceptions to that, but for the most part, when we're doing surgery on someone's spine, we are decompressing either the spinal cord or the nerves. And when you have a spinal cord or a nerve problem, it's not that your neck or your back hurts, it's that you have arm pain or clumsiness in your hands or leg pain, or you might have weakness in your foot where you're tripping over your foot. So really we're treating leg and arm pain as opposed to neck and back pain. There are exceptions where we can help with neck and back pain, but I think that we looked at a study at one point, and I can't remember what the statistic was, but it was like over 90% of neck and back pain has no surgical solution. Mm-hmm. So those are definitely not, the vast majority of people who we see who have those problems, there's not something that we can do for it. So the patient that we love, that because we can help and we have this great surgical option, is the person who has arm pain or leg pain, and they've tried to do physical therapy and it hasn't gotten better, and they've tried medications and it hasn't gotten better, and that's when it's time for surgery.
And to add on to one of the things that we can treat is it is very frequent that narrowing of the spinal canal, particularly in the lumbar spine, the lower back, can affect the nerves in a way that people don't necessarily have pain,
Yeah.
but they find it difficult to ambulate or walk long distances without needing a rest. Part of it can be painful. A lot of times it's because they feel increasingly like their legs aren't working as well, or they feel heavy and they really need a rest in order to basically, the nerves are getting kind of squished and they aren't working so well, and they need to give them time to relax a little bit. That's something we can also help with the decompression a lot of times. It's important to understand that very similar symptoms can happen because of poor blood vessel, basically function in the legs, narrowing of the blood vessels in the legs. But a family practice doctor, many physicians are very well trained at figuring out the subtle differences between the two, and an MRI of the lumbar spine can help elucidate a lot of that as well. So,
Awesome. Great. Switching over to a different sort of topic, and I'm sure you guys don't deal with headaches on a day-to-day basis, but I know a lot of listeners are out there being like, but I heard that one friend of mine who had a headache, and then the next thing they knew, they were getting brain surgery. So when does a headache become a problem for a neurosurgeon?
I'm doing so much talking. My chronic problem. I think
you're doing it well, though.
Two ways. So you as primary care, you probably know better the like red flags of headache, right? Like the mnemonic, I think we learned in med school, is to snoop or something like that. Those are probably fine, but the ones that always make me nervous are a patient with a history of cancer. So like colon cancer, it's always breast cancer, lung cancer, who now has a headache and never used to get headaches. That's concerning.
Okay.
And that person needs a scan quick, fast, and in a hurry, because that's concerning for brain tumor. The other kind of headaches that we see are Chiari, pseudotumor, increased pressure headaches. Brain tumors are increased pressure as well. But the unique feature of those headaches that most people don't have with their headaches is that they are worse with lying down. So a headache that is worse with lying down is a pressure problem, and that's atypical of most benign headache like migraine and tension headache, which typically improves with lying down. Similar to back pain, the vast majority of headache is benign, and I think primary care doctors and neurologists do a great job of scanning who needs to get scanned. We're lucky in that by the time they've made their way to us, that decision's already been made. So we kind of have this unique experience where the scan's already been done. We're not having to decide if somebody needs a scan or not. But I think headache with laying down is an alarming thing. And as somebody who has migraines, Dr. Sigler gets migraines too.
Yeah.
My headache always felt better laying down. So if you have a headache that is worse with laying down and you feel better with sitting up, that's odd.
And I want to basically pick up something you said, because I think it's a very important distinguisher. We have been headache people all our lives, right?
Yeah.
I come to it honestly through other relatives. I know the pattern, and I know what's going to trigger, what's going to cause, and I kind of can predict when I'm going to develop a headache. If you are a person who never gets headaches and you suddenly are having headaches and they're getting worse, that's troubling. That usually is an indicator that you have something wrong. The other thing that I would say is, and there's a very important entity that is neurosurgical, but also involves one of our other newer colleagues, would be aneurysm rupture. And so an aneurysm is basically a weakness of a blood vessel, and I think of it like a bubble on a garden hose that eventually breaks, and the bubble in this case is the aneurysm, the garden hose in this case is an artery, and what it leaks is not water but blood. Ruptured aneurysm, which causes what's called subarachnoid hemorrhage, which is a type of hemorrhage inside of the head, those are very concerning things, and there is a very specific pattern and a very specific name for that, and it's called a thunderclap headache. And it's basically because it comes on like a bolt of lightning, and it is one of the it's the worst headache of life is the way we describe it. Sometimes you can, any migraine sufferer can tell you it's the worst headache they've had, but it's more like this is a profound problem, and the people that experience it often know something's not right, essentially. But those would be concerning signs. That's not a wait and see, though. That's a go to the emergency room.
That's an ER.
Good to know. So who are some of the other types of specialists that you might collaborate with, and what kind of multidisciplinary approach do you use?
So where I trained, we had a spine center where we worked neurosurgery, orthopedic surgery, physical therapy, pain management, all under one roof to provide kind of comprehensive spine care depending on what the patient needed. And like we talked about, there's not typically a surgical solution for back pain. So most of those people are going to benefit from physical therapy where they're going to be stretching muscles that are too tight and strengthening muscles that are too loose in order to offload the stress on the spine to get rid of some of that back pain. Orthopedics, some orthopedic doctors can do spine surgery. It's a special training for them, whereas we come out of our residency being able to do spine surgery. But they sometimes have some expertise that we don't have. They do more complex deformity type things typically than what neurosurgeons do. So sometimes when you see somebody who has a really bad scoliosis or some really complex deformity to their spine, then an orthopedic surgeon is the better person to handle that. We also work with orthopedics, specifically the hand surgeons at Bayhealth, because they do carpal tunnel and ulnar nerve releases, which a lot of our patients have that. So they come to us with arm pain or hand pain, numbness, and it ends up not being a problem from their neck, but carpal tunnel or ulnar entrapment. So those are kind of the ones I was thinking of off the top of my head. You might want to talk about maybe working with ENT and stuff.
I think actually our list of collaborators is fairly long.
Yeah, that's true. Yeah, could just keep going.
Right, inside and outside, it's a little different depending on the setting. I think outpatient, we work very closely with our family practice and internal medicine colleagues. I have additional training in the skull base, tumors, which is basically anything behind the face or behind the throat is considered the skull base, essentially. So, or underneath the brain itself. That includes pituitary tumors, and I like to perform that surgery with the assistance of, co-operative with my ENT colleagues, because the best way that we approach that is actually through the nose, because the pituitary is basically right behind the nose, the nasal sinuses to be specific. And the pituitary is my territory, but the nose is their territory, and I'd rather have a person who knows what to do in the nose.
Knows the nose.
Exactly. To help me in that territory, because it has its own concerns and its own needs, basically. But in terms of other things, obviously for brain tumors, we work very close with oncology, neurology. Our newest colleague is what's called an interventional neurologist who actually does things very similar to interventional cardiologist, except instead of looking at the heart with a catheter, they look at the blood vessels of the brain. This is useful in strokes. It's also useful in the aneurysms, like I mentioned before, or any sort of vascular problem that can be dealt with inside of the brain. That's a very close relationship. Radiation oncology, also very close relationship. Pain management, orthopedics, physical therapy, occupational therapy. PM&R, rehab. We actually rely on our rehab colleagues a lot for all of our patients. So it's a wide list.
Yeah, even like ICU, because our patients are all in the ICU, and the ICU team manages every organ system except the nervous system. We handle the nervous system. They do all the heart, the lungs, the things that we just don't remember anymore. We talk to the internal medicine hospitalist colleagues every day when we're on call. Emergency medicine, we're talking to them almost every day. I call radiology at least once a week. It's almost every specialty that we end up kind of crossing paths with. It's fun.
So we've mentioned this a few times, and I'm sure there's some Eagle Eye listeners out there that have heard you say, "I can't fix your back pain with surgery." Well, what if they tuned into this episode because they were hoping you were going to do just that thing? What do you say to those patients that when surgery is not an option, and you hinted at a few with physical therapy, but what other modalities can they look into?
Yeah, really the answer is physical therapy. So, the trendy thing in healthcare right now is the root cause. And the root cause of non-operative back pain is a muscle and joint problem, right? And except for patients who have a treatable arthritis, like rheumatoid arthritis, psoriatic arthritis, anybody who doesn't have a treatable arthritis, they just have run-of-the-mill osteoarthritis, or even in the absence of arthritis, they have back pain. That's a musculoskeletal problem. And the only way to improve that is to offload the spine by strengthening the core, stretching the back muscles, strengthening the legs so that we're lying less on the back to move us when we're walking around. And that truly is the only real solution. Now, there are studies that have been done for interventional modalities, which are done by pain management, like spinal cord stimulator. Those studies are all very convincing in study form. They seem to help people. I don't place those devices, so I don't see the people that it helps. I only see the people who want them out. Yeah. So I get this kind of biased view of like, oh, does this really help anybody? But I think there are a large number of people walking around who are benefiting from their spinal cord stimulator or pain pumps or injections or things like that. But I try to encourage people as much as they can push through it, to do the physical therapy, because that is going to be the long-term solution rather than the Band-Aid that's just kind of covering the problem.
I want to add, and I want to throw actually I guess a bone towards you as well, because I think that one of the things that you emphasize, that family practitioners, internal medicine doctors emphasize, is diet, exercise, weight loss, health overall. And to go along with core muscle strength, I think one of the things that we often overlook is that there are so many causes for pain in the body, especially in the back. The back is made up of so many parts. There's only so much we can interact with as surgeons, and there are other reasons for it. And a lot of times it is simply because our muscles are atrophying as we get older, and we need to re-strengthen them, and we stop exercising, and it gets worn out, and it can't tolerate that as much. We've maybe got some extra weight, and we need to lose a little bit of it. And I'm not talking about massive weight loss. I'm not talking 20, 30 pounds. I'm talking 5 to 10, something that is easily done. I notice it when I actually lose a little bit of weight. My back pain is non-existent after that. The other thing is that there's a closely associated area. It's actually the joint between the base of the spine called the sacrum and the pelvic bones on either side. That causes an awful lot of what we describe as back pain, even more so than the other parts of the back. And it shouldn't be overlooked. The problem is it's kind of hard to treat, and it really does require several different modalities, also helped by weight loss. So diet, exercise, I know that's the first thing your doctor always tells you, but it honestly has a lot of impacts on a lot of things. And it's very helpful to get that under control. And that can be hard, we recognize that, but also if you can do it, you should try, basically.
Yeah, and it is, I do feel kind of rude to like tell people that. And also when I know they can't exercise because they're hurting, but as much as people can curb the calories that they're putting into their body, and I even tell people sometimes, like, do a weight loss drug, consider gastric bypass, especially for very heavy people that just aren't able to, get under control. And we know it helps. It's proven to help. But yeah, when there's no other solution, if that's all you got, that's what you got to do,
Yeah, we're not trying, I don't want to come across, we don't want to be
disparaging
or dismissive.
Yeah.
I was thinking more from the adage, we don't stop moving because we grow old. We stop moving, or we grow old because we stop moving. Right. And that is something that I also always usually tell patients when it comes down to this conversation is, we are not static creatures. We are dynamic creatures. We are always in motion. Every part of your body is working hard to maintain an atmosphere inside of it that is healthy all the time. All of your organs are always working for that. All of your cells, every single one of them. You got to help it out. You've got to help it out. And that means moving and teaching it what it needs to do and where it needs to put its attention. So
it's great to have both of you from Delaware here in Delaware. And we also have innovative tools that you use to do these surgeries. Can you talk a little bit about what we have here?
Yeah, so we have a couple like navigation pieces of equipment. One of them is a robot that we use for spine, and the other is a navigation equipment that can be used for spine, but we usually use it for cranial. So those just help us, make sure that we, cranial-wise, that we are performing incisions right where they need to be, small bone removals so that we can get right down where we need to work, as opposed to prior to having these devices, which is honestly before I was even in training. It's my understanding that neurosurgeons kind of just always had these tried and true operations that they did, and they just did it the same way every time, and maybe it was more than needed to be done, but they knew it would get them there. So now we're able to do things that are a little bit, I like to say they're like cuter, but like minimally invasive in terms of brain. And then in terms of spine, as far as spine, our spine robot allows us to place screws in a safe manner. We know how to place screws without the robot, but with the robot, we can make sure that they are the perfect trajectory, the biggest size that we could possibly get in that bone. Bigger screws are better. Bigger's better. So it just allows us to perform a more well-executed operation. And it's great that we have that equipment here, because although we can perform the surgeries without it, it allows us to do it in a more efficient way.
Cool. And to wrap things up, for our listeners who have been paying attention and might be thinking to themselves, I might benefit from talking to one of these neurosurgeons. How do they get involved? How do they contact with you? And how do they get a consultation to see if you have anything that might help them out?
Absolutely. Our preference is to basically have the person see their primary doctor first. We appreciate having you involved because if it ultimately comes down to surgery, we will need clearance from your primary doctor. The other thing is that primary doctors are well trained to understand, things that have multiple explanations or potential explanations, and it's not always clear cut that it's the thing, that you need to see this provider necessarily. So I think the first place to start is to speak to your doctor, but also we have offices in Dover, and we also have an office down at Total Care in Milton. We're only there right now once a month, but we have plenty of clinic time in Dover available. We also have several what we call APCs, which are nurse practitioners and PA, that are assisting us and also seeing patients when it's maybe not clear yet what they need. So we have plenty of opportunities, but our main office is in Dover, and we of course see people at the hospital. We don't really see people at Sussex, but we are available for consultation, and if we think you need to come up, we'll bring you to Kent, but that is our sort of main operative hub. So anything you want to add to that?
Yeah, I was just going to say that I could see why a patient would want to reach out to us and be seen, because they know they have a problem with their back. Maybe they were told years ago they had a problem with their back. Maybe they've had previous back surgery. But we really appreciate when it comes through the primary, because we want to make sure that we have the imaging that we need, and that this person is even an operative candidate. We don't want to waste the patient's time, and we want to make sure that the visit is as valuable as it possibly can be for them. So we want to make sure that we have all the information so that we can educate them or sign them up for surgery if needed. So that's why we do prefer it to come through the primary. But we do see patients without imaging. We have our no imaging clinic, where we'll see people who have suspected pathology, and we'll order whatever testing is appropriate. That's normally with one of the NPs or PAs, and that's only in Dover. But yeah, really just asking the primary to send us a referral. We're happy to see anybody.
Exactly.
Good stuff. Thank you both so much for joining us, Dr. Melnick and Dr. Sigler. We appreciate your time, and that is it for this episode of Scrub In.
Thanks for listening to Scrub In, where we bring purpose and care to every conversation.
If you enjoyed today's podcast, don't forget to subscribe, rate, and review on Apple Podcasts, Spotify, and wherever you listen.
Stay connected, stay informed, and stay inspired right here with Scrub In.